Yeah, good evening. Team Kaizen Gastrocare, Pune Surgical Society, and the Colorectal Surgeons Association. Thank you for giving me this opportunity. Can we go live? Yeah, thank you so much. So, without much ado, how to choose laxatives according to the current guidelines. But I think I'm going to make a little brief introduction. So, an outline of my discussion will be, first of all, why do we have sphincters and what's the difference between the two sphincters? If you want to establish a dream colorectal unit, what would you think would be the standard of care in the world? Slow transit is constipation or otherwise. So we should know a little bit more about what colon transit is. In general practice, what we need to know is how to take a good history and examination. Then there are three phenotypes of constipation: normal, dyssynergia, and slow transit, which we will now talk about. And laxatives: when to start, how to stop. So let's discuss why sphincters. How did we get sphincters in the first place? So when life was in the sea, the fish had a bladder, but that bladder was just to float and to maintain balance. When life moved on to land, what happened was that we needed to lose our urea, and so we developed the loop of Henle, and the kidney started developing, and these kidneys got attached to the bladder. The balance which the bladder was giving, we did away with, and then the bladder became a muscular organ for storage for urine. So that's how we got our bladder in the first place. 2019, there was this beautiful article that the evolution of the urinary bladder as a storage organ was actually caused because we had to protect ourselves. And it was the selection pressure for the first land animals. And this was figured out by computation simulation. And so the sphincters actually gave us a survival advantage. How? If you would have continued to leak urine all along, then it would be, you would be an easy target for the predator. And we had to control it so that we didn't want to leave any scent behind. And this bladder was then controlled by the higher centers. And so we could control it even though we were exerting, coughing, or straining. What's the difference between the bladder and the colon? The Barrington reflexes. In urology, if you go, you need reflexes. Like before you want this meeting started, would you want to go to you want to relieve yourself? No, I'm fine. I can hold on for a bit more. I think I could go if I had a chance, but I think I must go now. So you could decide when you want to pass urine. It's not the same for stools. So these are the reflexes which decide these actions. So we can control at a local level, at a spinal level, and at a higher center level, because of which we have good continence and we can decide when to pass urine. Not so with stools. So we empty when it's convenient, else we can defer even if you are at full capacity. In animals, there is social defecation. They don't eat where they defecate. So there is this social defecation and they can decide where to do what. More important for survival, in case in this picture, even if one animal passes flatus, that is end game. So we need to control in such a way that for 10 to 15 seconds, if we have good control, whatever was there in the rectum goes back into the sigmoid. And we can not only at the full state, but even if the bladder is empty, the bladder can be emptied even when it's nearly empty, and it can be emptied efficiently and completely. Lots of differences between the bladder and the rectum. Enter Newton. We knew that the apple fell on his head, but it was not solids alone that Newton was thinking of. Liquids. How do liquids flow? So they say Newtonian liquids flow in such a way that it will go by shear pressure. But if fluids become thick, this is similar to stools, Bristol 4, that means semi-solid stools. But stools can be thicker, they can be more formed, or they can be thinner. And we need to have the rectum to control all this. You may also have a problem in case you have liquid stools in the rectum and gas, and now you wish to pass only the gas. So we have such a fine control, and the job for the rectum is much different than for the urine, and we can sense and push back what we don't want to pass and just pass the rest. But where does the stools then go to? It doesn't stay in the rectum. The rectum is not the storage organ. It goes back to the sigmoid. If you want to set up a world-class colon physiology center, what would you look for? So this is how the colon works. We have 10 liters coming to the colon, but only 200 grams stools is actually made out of it, because a lot of to and fro activity is going on trying to reabsorb all the water. And amongst this is a high pressure contraction, which happens 5 to 6 times a day, which is really high pressure to gather all the stools, bringing it down. So what you see on the top is something like what the kidney does, reabsorb water. And what you see below is now the colon is behaving like the ureter. And these contractions can start anywhere in the colon, but they will end in the descending and the sigmoid. What happens in the sigmoid is that there are pressure waves which are gradually increasing in strength, and they are coming down to the rectosigmoid sphincter, which is a notional sphincter of O'Brien, which is just a high pressure zone. What's happening in the rectum at the same time is it is a braking mechanism, so it is pushing everything back. So between the sigmoid, rectosigmoid, and the rectum are what we can say the sphincters, which are helping us to get control. The puborectalis is our voluntary control. Now you get the pressure to pass stools. So when you get the pressure, what actually happens is a high pressure contraction is pushing everything down to the rectosigmoid, and each subsequent contraction is carrying whatever is left behind, so that all the stools are now reaching the sigmoid. And if you don't get this call to stool, that means pressure ala. If it doesn't happen, then you're going to get slow transit constipation. So this is what we know as wake and go reflex, eat and go reflex. Please remember this because it is going to come later again. There's a lot that can be said about the sensitivity of the anus, which is a separate discussion altogether. But just I'm going to leave you with the message that plenty of receptors are there in the anus to do our job of discrimination. I'll move back to the rectum. The rectum is now sensing. How do we assess the sensation in the rectum? We use a system called barostat. So in case the barostat is put in the rectum, there are two sensors at the front and back of the balloon and two sensors in the anal canal. And if I blow up the pressure wave, it will look like this. You're inflating the balloon and there is a rise in pressure, which is followed by a fall in volume, which is actually a contraction. You may or may not make this out. This is the rectal contractile response, the first thing that you need to pass stools. This is also the pressure that you feel. Now you need to go. This is the call to stool that you get. As stools collects in the rectal pressure rises, the anal pressure drops, and this is what we know as the rectoanal inhibitory response. Now the play starts between the rectum and the spine. There are local wall reflexes which excite the internal sphincter and inhibit it, and there are autonomic reflexes which form the rectoanal excitatory reflex. Everything is between a want to empty and I don't want to empty. So these reflexes are only in research. We don't have the tools to check this. But the higher centers are telling you that this is not the right time to go and pass stools. So what happens is you start getting contractions which are high amplitude contractions, but they're going backward. And so there are orally directed high amplitude contractions which we can measure, which tell you this is not the right time to pass stools, and they are cyclical. But if it is the right time to go, how will you test the rectum, which is motor? So you have a Fecobionics device in which there are pressure sensors in the front, pressure sensors at the back, and when you push to pass motions, you have a pressure wave which is pushing outward, whereas from behind the balloon is being pushed, and there is a delta wave which is efficient emptying of the rectum. In case The rectum doesn't empty completely. This is dyssynergic defecation, in which there is a flat wave, and patients with incontinence have a very small contraction resulting in a very quick evacuation. The same balloon, if you pass barium and see it on an X-ray, will look like this. The new point about this Fecobionics device is that when you are passing stools out, it measures the pressure as the balloon is passing through the anal sphincter. So you have real-time anal sphincter measurements till it drops out in the commode. And in case there is a weak sphincter, it needs very little inflation to pass out. This balloon can also detect angulation, and this is the device bending, the straightening, as well as dyssynergic defecation. You can even add a camera to the tip of the Fecobionics balloon, and it will show you what we know as piles are actually anorectal cushions. And when we want to pass flatus, you can actually see these anorectal cushions opening to show continence of flatus. So everything in a high-tech center can be seen real time. What is slow transit? Is it always that you have slow transit when you are talking of constipation? So there is a test which we do, which is a colon transit time, and it is spread out over 5 days. So we give 12 capsules, and each capsule contains 5 markers. So we have 60 markers. These are medically safe, and the shape can be seen very easily on X-ray. You take 4 capsules at a time on 0 hour, 12 hours later, and 12 hours after that. So you have taken 4, 4, 4, and then you're telling the patient not to take any laxatives after that, till all the X-rays are done. You will ask the patient, go to any X-ray center, it has to be only a digital center, close to your home, and ask him for a plain X-ray abdomen pelvis lying down. The technician asks, ye kya hai? You say KUB. I want the diaphragm and I want the pelvis. So you do an X-ray at 36 hours and you do an X-ray at 60 hours, and this is the end of the test unless there is a slow transit. When you see the X-ray, you drop a line till the L5 and the sacral spine and the iliac crest. So you have divided the X-ray into 3 parts. There is a right, left, and the pelvic part of the X-ray. And in Indian studies, Uday Ghoshal has shown that 30 markers or less at 36 hours, 14 markers at less at 60 hours is normal colon transit. So this is a X-ray which was sent to me from Bigwan. So you can imagine, I just give him the capsules and he goes. And from his village, he sends me the X-ray, from which I can tell him that this is normal transit, 30 markers at 36 hours and 14 markers and less at 60 hours. In this X-ray, there were very few markers even in the first X-ray. But you can have an X-ray like this, which is slow transit because there are larger number of markers, and this will be slow transit constipation. And if all the markers are piled in the pelvis, then this is a pelvic floor dyssynergia. You can also have X-rays limited themselves to the right, to the left, and in the pelvis, but this is a subject for another discussion. How do you take an history in a patient with constipation? You can find all these things which I told you of technology just by history. So how do you get to there? So I have compiled a paper from 2013. This is the Asian guidelines, the Indian paper at 2018. They are the Seoul guidelines 2022, which are the latest for Asia. And there are some guidelines which have come from the Rome, because Rome used to say, ask the history for the last 6 months. But now they understand that you can have occasional constipation, which also needs to be recognized as an entity. So these 4 guidelines I have now taken together. Initially, you will always want to find out whether the patient has alarm signs and he needs to go for a colonoscopy. So this, everybody knows the typical history in which you would not consider this patient as a functional, and you would also rule out rectal prolapse on history alone. Now, if you want to examine a patient, what are the questions you'll ask? The first question is, what is normal for you? There are people who go 3 times in a day, which is normal for them. There are some people who will go once in 3 days, which is normal for them, and then that becomes the benchmark for their treatment. You would also then ask, what is your reflex? कळ केव्हा येते? When do you get the urge to go to the toilet? Do you go when do you wake and go? I showed you that reflex which can be elicited. So do you wake and go? Do you eat and go? Or you go with all the meals? So you need to know when is the reflex, because from there all your treatment is going to start. So do you then respond to that reflex? We get mothers who tell me that मेरे बच्चे का दवा बनाना है, उसको स्कूल को भेजना है. So everything is done. Then after that I go and sit on the pot. But by that time, the high amplitude peristaltic contraction has taken the stool back to the sigmoid. What is going to come out now? So you need to respond. Do you squat when you pass motions? And this is a typical example of a squatty potty, where you have pads which allows the friction not to displace your legs, as well as you can have an erect posture so that you can bear down properly to open the anorectal angle. Can you initiate defecation right away? You go, you respond, you sit, and do you get stools? Very important, because those people who do not initiate are patients of Rupali. How much time does it get you to get done? Less than 5 minutes or more? And some questions which probably take the patients to the surgeons. Do you feel incomplete? Is a sense of anorectal blockage? And do you need maneuvers to assess defecation? We'll talk a little bit more about the Bristol score. And to complete the list of 10, medication and digital rectal examination, these are the 10 questions you're going to find with which you're going to get the diagnosis of constipation. So to look at the Bristol score, this is my table where I do my consultations, and many doctors have their family picture on the table, but in gastroenterology's rooms, we have pictures like this, which is actually one of our tools. This is the Bristol stool score, in which type 1 stools, very hard, transit time is 100 hours, and very loose stools, transit time is 10 hours. So just seeing the picture of stools tells you what it could be the colon transit time. And this is a pediatric scale in which they have suggested that the parent should look at the common shape of the child's stool. So you can easily use this tip and say, commonly, where do you put your stools? So in case all your questions are on the left of the screen and a little bit off the top, and the Bristol score is not very bad, you're looking at a patient who's having normal transit constipation. In case you may not be going daily, you may be sitting for very long, but your stools are very, very hard, you're looking at a patient who's likely to have slow transit constipation. But on the other hand, if all your questions are on the other side of the screen, and there is a lot of maneuvers that the patient does, and the digital rectal examination is going to show some abnormality, you're looking at a patient who is having dyssynergic defecation. So what is the digital rectal examination? Now, this has been enshrined by the Indian Society of Gastroenterology as a protocol in which you are first inspecting and making sure that you have got all the anatomy right. You are eliciting the sacral reflex by touching the skin and seeing that the sacral innervation is intact, after which you pass your finger and see the thickness of the puborectalis muscle, and then you ask the patient to contract the sphincter, and what you will see is the sphincter is moving towards the abdominal wall, and in case you bear down, then you can see the sphincter moving down, and the hand on the abdomen is actually making out that you are really bearing down. This is the way to find out the reflex. You take out the finger and look for blood on the examining finger. The surgeons in the hall know everything, but this has now become a part of Indian Society of Gastroenterology. Normal transit constipation, what is it? It is not constipation at all. It actually means that this patient may be having lactose malabsorption, or he may not be tolerating wheat. It can be a part of post-infectious change in bowel habit. He may not be tolerating adrak, lasan, pyaz. These are all the contents of these foods are FODMAP. Indians are vegetarians. They have a different gut microbiota, and they also has a role in developing symptoms of irritable bowel syndrome, but also this can be a psychological state in which anal retentive behavior, which is seen in children or it is seen in adults, the typical A-type personality who comes to your OPD, I have constipation, I've tried everything. And he's the person who probably will demand medication, but you might find that there is nothing in him, but it's just his psychological state. This synergic defecation is going to be taken by the next two speakers, so I'm not going to dwell on that. And in slow transit constipation, you know exactly what it is. But what, as gastroenterologists, the extra that we do in case we need to find that out, you need to know that there is a Onuf nucleus which is at T12L1, in which the innervation is not only somatic, but it is also autonomic. And that's what makes it very unique, because since it has both the innervations, your autonomic functions are also controlled through the spinal cord. And so your higher functions can influence this. The reason I'm eliciting this is that in a patient of slow transit constipation, you need to see the spine in great detail. So what would you look at? A few things. Brainstem lesions could cause this. Stroke syndromes, you need to know. Patients with multiple sclerosis, they could also present early with this. And high CNS lesions, obviously, they are actually far gone. Cauda equina lesions can also cause slow transit constipation. There are drugs for neurological conditions which can cause slow transit constipation. Very important to know Parkinson's disease. 2 years before Parkinson's, patients start getting constipation. The incidence is very high. And we have very typical findings on anorectal manometry, which I won't dwell on at the moment. But the medication given for Parkinson's slows down the gut as well as the stomach and the colon, and you are actually worsening the constipation. So there is a futile attempt of the neurologist who is trying to give stronger and stronger medication, whereas if you give strong laxatives early in this constipation, you will prevent the stasis from happening. So you probably might help your neurologist by choosing to use stronger laxatives in this slow transit constipation. You may even tell your neurologist that I have diagnosed the Parkinson's for you. Parkinson's basically starts as a peripheral disease, and what has been found is that there is an immunohistochemical marker which can be seen in the colon biopsies of patients who develop Parkinson's later. So if you have done a colonoscopy and you have found slow transit constipation, there may be a day when which you might take blind biopsies and you send it for this immunohistochemical marker, and you might find that this person develops Parkinson's later. So these are just the outliers of slow transit constipation. How to choose laxatives and how to customize them? There is a decision tree. The patient has to participate. You can't write a prescription and go. It doesn't happen. You remove all the factors that you can, which means you look at his prescription list. Hematinics, acidity ki dawai, respiratory medications, pain medications, oxybutynin for the bladder, antidepressants, and medications for blood pressure. You need to go through this all because you will find that these are confounders in the constipation. You need to increase fiber. So we tell how much fiber, the dietitian says increase it to so much, but you need to remember that you need to increase slowly, 3 grams to 4 grams per week, otherwise these patients get bloating. Now the juice of the prescription, what are the medications you need to give? In the guidelines, this part comes right at the bottom, but it is to be prescribed right at the top. So if you have hard stools at the start, mineral oil as lubricant, and in those patients who bloat and constipate, remember to add probiotics right at the start. You have fiber, which I'm not going to talk too much upon. We know that lactulose is a very safe laxative, which is nowadays standard of care. And milk of magnesia has gone out because it has a renal toxicity. But in case it is used, it has to be given in this dose. PEG is again standard of care. Remember that those medications which contain sorbitol, they act as laxatives. Sorbitol can also get uh, absorbed into the colonocytes, and there is no way for it to come out. And that's why you can have sorbitol toxicity, but that's a different topic. Those people who need sorbitol as a laxative one time, this is the dose that is given to them. There are stool softeners which are used in this dose. Academics, nowadays, I don't think it is standard of care anywhere. And then come to the big daddy of all prescriptions, the stronger laxatives. So we know this is a prescription, this is a drug which is abused. So these are all anthraquinone, glycosides, and phenolphthalein, Senna and Cascara. About this, there is a statement which reminded me of Baba Ramdev. The Canadian healthcare has actually developed guidelines for preparing a product license application and labels, something which Patanjali will never do. But this is what is standard of care when you want to prescribe Senna. They are doing it abroad. We know Gervisa and we know picosulfate. Both are converted to the same active ingredient. So we cannot change from bisacodyl to picosulfate because they are in the same class. Both are prodrugs. The dose is, everyone knows, but just as a repetition, bisacodyl 5 to 15 milligrams and sodium picosulfate 5 to 10 milligrams, half dose for less than 5 years. The prokinetics, we knew that cisapride and tegaserod went away because they had cardiac toxicity. So this drug binds to 5-HT4 and it binds to another HERG potassium, and that's where the toxicity is. Flucalopride binds 150 times more to the 5-HT4 and that makes it safe. I don't know how much it binds to HERGK, but this is why it is safe and you have lesser cardiac side effects at 1 to 2 milligrams a day. Then the stronger laxatives are called secretagogue. So lubiprostone is a calcium channel activator, calcium and bicarbonate, linaclodide, not yet in Indian market. And ilobixibat has just entered the market. It works on creating a lot of secretions in the right colon, which will then move everything to the left. The only problem is you need to give it on an empty stomach 1 hour before dinner. So now, what to do with the people who are only having short-term constipation? The guideline says use the stronger ones right away and then the other ones. And if you have constipation type of IBS, then it's bisacodyl. But pain predominant IBS short term, you would use polyethylene glycol. How to stop laxatives? Why stop them? So this is a paper which is coming from the UK, in which the findings support that you can have more falls in patients who use laxatives. Though these patients are using everything to put calcium back into their bones, it is not working because the laxatives are removing it all the time. And so you need to keep looking at their prescription and trying to find out why they are likely to be at a higher risk of fall. There are the longest study is 40 years, and they found that Senna, of all things, is the drug which would be safe. It actually is not a very contentious statement to make. So, what do you tell people who are constantly using fluids? So, this is an animal study which I found in which they gave the same fluid to rats. And what happened was that this study tells us more about what a cathartic colon looks like, including melanosis coli. But they gave these rhubarb drugs in a dose by which they reached a point where the rat started getting a diarrhea, and they kept it at that dose for some time. And after that, the diarrhea stopped. Then they increased it by another 200 micrograms. So they created tachyphylaxis in the rat. And what they found was rats get use two Stena laxatives within 1 to 3 months. So looking at the rat's life, in 1 month the rat gets used to Stena. Now you can extrapolate to 2 months. So you are likely to get habituated to Stena laxatives. How do you stop them? No way, there are no guidelines. But what I found in the UK was they have clinical knowledge summaries for patients, so the patients can go and help themselves. You came asking me for a laxative. Now you find out how you're going to get off it. The doctor may not be able to tell you. So in 2 to 4 weeks you're going to be fine, and you should start trying to de-escalate, and you should wean in such a way that which you don't need a rescue therapy. And begin by removing the stimulant laxative first. So you remove the propanopride. At that price, you may need to increase the dose of PEG so that you can get a good response. And it might take months for all this to get over. Relapses are common. And those people who are on drugs like pregabalin may not be able to get off. And those people who have already a slow colon may not be able to de-escalate. How to prevent this? So here AI comes into the management of preventing constipation. From China, they found that age, anxiety, action, exercise, certain things which we never associated with constipation. These are things which they need to be vigilant about early in the management of their diabetes so that they will not get constipation later. And to prevent constipation in diabetics, there might be a day when nomograms which will be driven by AI will tell the doctors how they will not get permanently into slow transit constipation. Thank you so much for this.